So really important about interpreting a DEXA scan. And this is what your final report is going to look like. So when you get a printout, either electronically or you get a printout, it's a PDF sort of page and it's an A4. And this is approximately what it looks at. So it gives you all the patient details at the top. It gives you the areas that are scanned. And then it gives you your lumbar readings here and it gives your femoral readings over here. And again, it pops a little black dot. You can see that little black dot and a little black dot there as to where the person falls in the whole sort of continuity of normal bone all the way to severe osteoporosis. You can see where that person is relative to the numbers. Now, through here, we've got all our measurements. So if you're looking for your specific numbers, this is where you want to go. Specifically, your T-score and your Z-score will be in this table over here, and I'll explain what those mean. So you've got your nice visual reference, which shows you straight away where the person is, either in the green, yellow, or red zone, and then you can come down here to see the actual specific numbers that you're dealing with. Okay, so again, that's the lumbar spine that's been scanned. A person has dropped down into the yellow. And essentially, this is where they are in terms of the relativity. So that's your bone mineral density, grams per square centimeter. And then what you've got here is a young adult. So it depends how the machine is calibrated, but it's normally a young person around about the age of 25 or 26 years, which would be when they're at their peak bone mass. And that is your T-score. So your T-score is very, very important. And that is against the best bone that you could potentially have. The Z-score is age match. So it's seeing where the person is in comparison to another person of the same age as them. So there should be less of a difference at the Z-score, and you must probably see more of a difference at the T-score. So the T-score is telling you how much you have declined from that peak bone mass. And the Z-score is telling you how you sit within a group of people the same age as you. So the T-scores have got various different parameters, which we'll go through as well. But again, here is your number here. So it's giving you a different number for each different vertebra. And then if you're doing the femoral neck, it just gives you the femoral neck as well. And then you've got your Z-score through here. Okay. So your T-score, if your T-score is greater than or equal to 1, you've got a normal score. So you are either better than or equal to a young person at peak bone mass. So if you are 26 years old and you had a DEXA scan, you would ideally want your T-score to be 1 or greater than 1. When you start going -1 to -2.5, you're into osteopenia. So you're now below the reference ranges. And if you are greater than 2.5, sorry, it should actually be 1 to 2.4. Once you hit -2.5, you're now into osteoporosis zone. So if the number is less than or equal to -2.5, well into osteoporosis. And if you are greater than 2.5 and the person has had a fragility fracture, then they are classified as having severe osteoporosis. So fragility fracture would be a vertebral compression fracture, would be a distal radius fracture. And in some units, and certainly in Australia, we include ankle fracture with that as well. So it does depend on the mechanism of the ankle fracture. Obviously, if someone was jumping out of a building, out of the second story, and they have an ankle fracture, that's not really considered a fragility fracture. But if someone is walking, turns their ankle over and ends up with a fracture, we'd consider that more towards the end of fragility. So greater than or equal to 1 is a normal. 1 to -2.4 is osteopenia. 2.5 and less is your marker for osteoporosis, and -2.5 with a fracture is severe osteoporosis. And that's T-score. So T-score is when you're comparing against young, fit, healthy bone and peak bone mass. So normally someone around about the age of 26. And then your Z-score is a comparison to the same age, the same sex, and the same ethnicity. So this is where you can see where you are sitting amongst a group of your peers. So if you now have a Z score that's greater than -2, that's normally because there's something else going on. So you either got some kind of malabsorption, you're taking some kind of medication, or you've got a parallel endocrine issue as well. So Z score, I remember Z the same as in the same. It's easier for me to say, whereas T score is the healthy. So I kind of think T is top. So T is the top you could ever be, and Z is the same, or the same is the way I remember the two. Okay, now there's different regions of interest. Remember I said there's the lumbar spine, there's the femoral neck, and then there's the distal radius. So we're going to look at each of those. So essentially what happens is when you get a DEXA scan, you get a variety of different images depending on your software, depending on your scanner. So you'll get a whole range of these type images at the top or variations thereof. What you're interested in are these bottom images here. So here's your femoral neck. There's the femoral head. There's the greater trochanter. And again, here's your femoral head, femoral neck, greater trochanter, and the shaft. And this is taking into account the total hip because you're including the acetabulum in that measurement. So your box tells you where that measurement has been taken. So if it's through right onto the inner pelvis plateau, then you know that it's a total hip that has been. So the lumbar spine is particularly good looking at early disease detection. And this is because you've got a high trabecular bone content. So it's really good for your standard DEXA scan, but also if you have the ability to do the trabecular assessment, the lumbar spine gives you a really, really good assessment for that. However, it is challenged by degenerative change. So a lot of people, particularly when they start getting elderly, have advanced degenerative changes. It's one of the reasons they saw. And again, if they have got osteoporosis, they've generally got sort of some collapse and some bony changes happening. So you can then have issues because the person's got facet arthropathy. There may be osteophytes present. There may be calcification of the aorta. They may have a scoliosis, which means capturing the actual anatomy can be challenging. They may have already had some fractures, which again means outlining the anatomy can be difficult. And all of these can tell you sometimes that they've got a higher bone mineral density than they actually have, because these are things that fool the machines. So particularly your osteophytes and particularly your facets arthropathy can sometimes give the indication that you've got a lot more bone mineral density than the person actually has. And then when they scan the hip tends to have less marked changes than you do in the lumbar spine. So generally in the hip, you don't have as many osteophytes. You don't have the facets to confuse the issue. Generally with the hip, you end up with a loss of joint space. You end up with subchondral sclerosis, so it's an isolated area. You do end up with some bony cysts, but again, that kind of gives you a bit of an accurate reflection because you do have bone loss in those areas. So this is where we include the total hip, which is including the acetabulum, because the acetabulum gives you a good idea of the bone stock that you've got as well. Whereas your femoral neck has the highest fracture correlation. And that makes sense because if you are going to fall and the femoral neck has got a low mineral bone density, you are then going to fracture the hip. So chances are if you've got a low score in that region, you are going to fracture your hip. And if you have fractured your hip, it makes sense in the reverse that you will have had a low score in that area. Now, the forearm is used in a number of different scenarios. So if the person has got hyperparathyroidism, and a lot of that is because you end up with changes in the spine, which then affect the reading that you've actually got. Some people have had bilateral hip replacements, which means that you essentially don't have a hip to scan because they're metallic, or they've got severe spinal degeneration to the point that you just don't actually get any sensible numbers out of the scan. The principle is exactly the same. So you're just going to see a different piece of anatomy on your scout view, but the interpretation is going to be the same. So you're still going to get your dot on your colored graph in terms of where the person's falling. And then you're going to look at your table. And over here, you're going to look at your T-score, which is the score against the top bone mass, which is, again, a young person at peak bone density, versus your Z-score, your Z-score, against a matched cohort of same sex, age, and ethnicity. So you've got 2 points of comparison. So just to go over this again, your falsely high bone mineral density, if you've got osteophytes, if you've got osteoarthritis on the facets, if you've got a scoliosis, aortic calcification messes with the algorithms as well. And then if a person's had vertebroplasty or they've got surgical hardware in place, calcified ligaments, so ankylosing spondylitis, or if the person's got obesity, because you then end up with having to use a high penetration to get through. So this is a vertebroplasty. Not everyone knows what a vertebroplasty is. So the way we do this, it's not something that's regularly done in Australia, but I do a lot of these in Europe. So essentially you have this fragility fracture where you can see the wedging on the anterior part of the vertebral body. What we do is we then put a big trocar down the back of the pedicle, so through the pedicle into the vertebral body, and we then inject cement into the vertebral body. Now, the issue, there's 2 different ways of doing this. So we can just put the big sort of hollow needle down, we call it a trocar, and inject the cement directly, which is very high pressure because we're forcing the cement against the bone. Or we can do something called a balloon kyphoplasty, which is we put a balloon down, blow up the balloon, which then pops everything back up again, take the balloon out, and then put the cement into the cavity that we've created. So there are different ways of doing it, but if someone talks about a vertebroplasty or a kyphoplasty, that is what we're talking about. And this is what you see on the x-ray. So this is bits of cement that you're seeing. So often what happens is that if a person's having ongoing deformity, they're becoming very, very kyphotic, we do this. And the other time we do this is if a person is having significant pain, it just stops the further collapse. And there's something about the exothermic reaction that happens with the cement that potentially knocks off some of the sensory fibers around the end plate. So it's not going to magically correct a curve. It's more about stopping the person getting any worse rather than any correction, and also managing some of the pain. You can get a false low bone mineral density. Generally, this is because of poor positioning. So this is the importance of having the hip internally rotated, those legs internally rotated 15 to 25 degrees. And that's so that we get a full profile of the femoral neck and the femoral head because of the anteversion. The person might jiggle around, might move, particularly if they're a bit restless. You might select the wrong region of interest. So again, we might be looking at, we might be slightly off with, so we do a scout view, we then hone in on our area of interest. You might not be accurate with that, which then throws you off a little bit. Or the person may have osteolytic lesions. So as I said, in the femoral neck and the femoral head, sometimes with severe osteoarthritis, you get cystic changes, and that doesn't really happen in the spine, more in the facets. We can get some of those changes. But it's the femoral neck, and sometimes we get them as well in the acetabulum, which really makes interpretation a little more challenging. So does anyone have any questions before we go on to the last little bit? There's not a huge amount to talk about with DEXA scan, and we're going to do a bit more practical interpretation in the tutorial, but does anyone have any questions about anything we've gone through? Have I said anything terribly confronting for anyone? Everyone good? All right. Okay, so just to remember then, as we go on to that, some take-home messages. So the gold standard for osteoporosis is your DEXA scan. So even though it's X-ray, even though it's ionizing radiation, it actually is fairly low radiation. Gives you a very highly accurate bone mineral density measurement, and it is the international reference for T-score based diagnosis. So if you are wanting to start someone on osteoporotic treatment, particularly if it's some of the more significant sort of higher level osteoporosis treatment, you need to have a clinical justification. And the gold standard for this clinical justification is your T-score. So remember, T-score is matched against the top bone mineral, which would be a young person around about the age of 26. So T-scores diagnose and your Z-score contextualizes. So your T-score gives you the diagnosis and your Z-score puts it into context in terms of where that person is positioned with their peers. So your T-score gives you your osteopenia versus your osteoporosis in adults, and your Z-score is comparing to the age, sex matched norms, and this can be useful in the younger age group. So we generally don't do a DEXA in someone who is, still a pediatric patient, so under the age of 16. Incredibly rare to do that unless you have some kind of endocrine disorder that you're monitoring. But essentially, if you have, say you suspect a parathyroid issue with someone and they're in their 30s or they're in their 40s, this is something that you would want to quantify specifically. And if we have someone, one of the times I use it as well, particularly in younger groups, is if I'm having to do any spine surgery and I want to put screws in to actually hold either a correction or I want to do a fusion. I need to be sure that my screws are not going to just pull out the bone, that the bone isn't so soft that everything's going to fail, particularly when I've put a person through a spine surgery. So sometimes we then just do a DEXA preoperatively, just to make sure that whatever hardware we put in there is actually going to go the distance. You want to look at your regions specifically. So in your lumbar spine, you know that you are susceptible to that metabolic change, but you also know that there's a much higher chance of degenerative changes. So you need to see that in context and you need to be aware of that. In the hip or the femoral neck, that is your greatest predictor of fracture risk. So if someone does come up with a high fracture risk on the hip, you really want to make sure that you've counseled that person, hip falls prevention, vitamin D supplementation, calcium supplementation, and really optimize their fracture management. Basic advice as well against falling, make sure if they've got a four-wheelie walker or crutches that the rubber stoppers are in good condition. Advise that they don't have any loose mats in the house, that they've got good lighting, because it's normally the simple things like that that cause people to fall. And we do the forearm if they've got artificial joints in the hip, or if they've got hyperparathyroidism and the spine just isn't suitable for us to image. So image quality matters. So you really need to go with a reputable service who really takes a lot of care with their positioning and their algorithms in terms of consistency. And that's really, really important for serial considerations, because if you are going to diagnose someone with an osteoporosis or osteopenia, they then start on the intervention, they start on the medications, they start doing whatever's been prescribed, and you then want to see them again in 6 months or 12 months, you want to know that you've got a comparative scan. So you want to make sure that your facility is taking care with how they're positioning accurately, and are taking a lot of care to calibrate everything again as best as possible. And then your guides management, so not just your diagnosis. So your DEXA is really informing your risk. So one of the things you can do, which I actually forgot about putting in, is something called a FRAX measurement. So FRAX, it's there on the slide. If you just type in FRAX into Google, it will take you to a website where it's a free calculator and you put in various, it will ask you for the patient's age, ethnicity, sex, a few other details, and you put that in and it will actually give you the fracture risk assessment based on that. So it's actually a very, very interesting site. Have a look at it. It's free of charge and it's a great site, particularly for educating patients.